Hello and welcome everyone to our webinar today. I'm just giving a few minutes for people to join, but welcome all. So maybe as an introduction, so my name is Joy Moher and I coordinate the Mental Health Innovation Network. And I'd like to welcome you all to our webinar today on reforming mental health systems and services with lessons from the WHO Special Initiative for Mental Health. And we'll hear more about the implementation learnings on reforming mental health systems and services and discuss experiences from WHO Special Initiative for Mental Health countries. So today we'll hear from Dr. Dan Chisholm, who will give an overview of the program. And next, we'll hear from the different implementing countries, and we'll hear experiences from Bangladesh by Hasina Momotaz and experiences from Argentina by Liliana Urbina. Please feel free to use the Q&A section to ask questions, as they will be addressed by the panelists as we go along. And we'll also have a Q&A section at the end, which will be led by Giovanni Sala. So to start us off, I'll invite Dan Chisholm.
Great. Thank you very much, Joy, and welcome everybody on behalf of the WHO team. Great to be back. Of course, this is the second of the webinars devoted to this WHO Special Initiative for Mental Health. There was one in December that many of you may have attended. If not, I think there's a recording of it available for you to view. So in a minute, my name is Dan Chisholm. I work in the Department of Mental Health and Substance Use at WHO headquarters, and I'm speaking beginning on behalf of the core secretariat team for this program of work. But most of the work is done in the countries, and we'll be hearing from two of those countries that are participating in this initiative in a few minutes' time. What I thought I could do is quickly, particularly for those who may be new to this, give an overview of what this program of work is about and what it's trying to achieve, but also say something about what's already been achieved and what's been the impacts and what are some of the reflections and learnings to date. So with that, Lydia, if I can go to the next slide and we'll start off. So the WHO Special Initiative for Mental Health, the vision is a big, broad one. All people achieve the highest standard of mental health and well-being. But it's really around two major objectives or actions that you can see listed there. One's around in the policy space and advocacy and human rights. And then the other one is more around the scale up of effective interventions and services at the community level. So through this program, we have an ambitious goal to ensure access to good quality and affordable care for people with M&S conditions for a further 100 million more people. So we're well on the way to that goal, as you will see. But we're able to have such an ambitious goal because we're working in currently in 9 countries across all WHO, 6 WHO regions of the world. The countries are listed there, and we'll be hearing specifically from the first 2 today, Argentina and Bangladesh. But as you can see, some of these are very large countries, and so we can have these kind of ambitious goals to reach many, many millions of more people because of the size of those populations, many of which currently have substantial unmet needs. Next slide, please. So in terms of what was planned for each of the countries, a very typical, if you like, project cycle. We started with nomination of countries through the regional offices and initial agreement with the member states and the ministries of health concerned. And then each of the countries, we've formed a detailed situational assessment to understand the current context and the policies and the service activities, as well as what kind of activity and services are being provided at facility level. We then went through a detailed planning process and developed a work plan through using a structured log frame, and also developed a monitoring and evaluation framework, both indicators that could be used in each of the countries, but also cross-country core indicators that we can use for the program as a whole. And then once we've established a workable plan, implementing that, starting with some money, a budget allocation, and then delivery and monitoring of a annual work plan year on year, starting with a lot of initial policy engagement activities, moving into capacity building and training, and then more latterly into actual service delivery in new districts of the countries concerned. And of course, as we go along, we are monitoring. We've had a midterm evaluation of what has been achieved and learnt. And in due course, we plan to hand over and conclude the funded activities and embed the existing activities into national programs. Next slide. So that's the kind of policy cycle way of looking at it. But what about the actual content? So these are some of the themes or topics that commonly appeared in many of the log frames or work plans. And it's a kind of blend of, service-related issues around, for example, integration into primary healthcare and other programs. A focus in some countries on looking at training on quality rights, which is one of the flagship WHO initiatives as well, but also some system strengthening issues. And I think this is one of the points that sort of separates it from this program work from many mental health innovations and projects. The ability to assess and perhaps influence the systemic environment and issues surrounding service provision. So whether that's sort of governance and leadership issues, financing, workforce, and health information systems are examples of what I mean. Next slide, please. And then here are some examples across the different countries of what I mean, some specific examples. We'll hear more from Argentina and Bangladesh, but a couple of examples. So in Ghana, for example, they have been working in a number of the regions in the country to develop and integrate mental health services in non-specialist settings, and also have been successful in increasing the budget allocated for mental health. In Ukraine, extraordinary things have happened, even in the very challenging context of the ongoing conflict, to not only roll out mental health and psychosocial support to those in need, but also to develop a whole new set of services, integration of mental health into primary care, but also community mental health teams, which had never existed before in that country, which are providing community-based services and support for those with more severe mental health conditions. And a raft of other examples that you can see there. Next, please. And the impacts to date. So up till the end of 23, this is kind of some high level numbers. And of course, behind that, there's a lot of stories, some of which you will hear in a moment. But just to give you a sense of the scale of the of the program. So across these 9 countries, I put in sort of 5 different kind of let's say almost stages. You know, there's engagement, and then I was talking about the training and capacity building, and then actual provision of services. So if we just look at some of those, nearly 900 organizations have been engaged or mobilized. The numbers of providers, not just service providers, but also people involved in policy. It's a pretty huge number, like 30,000 people across the countries. Much of that has been on the service delivery side, including training in MHGAT, which helps those working in non-specialized settings to identify and manage priority mental health conditions in primary care. And then perhaps the biggest and standout number, I mentioned this goal of reaching 100 million. So you can see we're just over halfway, 52.8 million new people reached through this program. And I'll show this and the number for the next one on uptake and coverage, nearly 500,000 in the next 2 slides. And then almost, you know, most importantly, you could say, what about the actual outcomes for those who have come into contact with services? And for that, we are in the last stages of planning a sentinel survey in several of the participating countries to assess those over the course of this year. So if I look at the 3rd and 4th ones, so one's around, what do I mean by, yeah, that's fine, Lydia, you can go ahead. For the access and availability, how do we measure that? What do we mean by that? So we've actually defined it mainly in terms of catchment areas that are now served by primary healthcare facilities, which now have that capacity to identify and manage M&S conditions. So when we talk about access, that means potential use, and it could mean, so it's a sort of population level concern. And you can see the numbers vary enormously actually across the country. Some have seen really spectacular increases, most notably Ukraine over the course of last year. But many other countries have also made really substantial increases. You'll hear from Hasina in a minute about the work in Bangladesh, for example. Okay, let's go to the next one. So that's access and availability of services which weren't there before. So that's sort of population level concern. Whereas the actual uptake of services is more an individual level measure. And it's trying to capture numbers of people in need who are now in contact with services and hopefully benefiting from them. So this is a much harder number to actually capture and measure. One of the learnings is, the difficulty in capturing that in some of the countries. And we're probably undercounting some of these, but you can see again, and for those who are with keen eyes will see that this is actually on a logarithmic scale. So you can see that the numbers actually vary quite substantially again between countries. Some are only just really getting going, others are making great strides already. Next slide, please. So final one. So just some reflections to date. So you can say that the really very substantial amount of time in the first 2 or more years was spent building up relationships and partnerships and collaboration and agreements and buy-in with the core partners. So the take-home message is that this really can take a lot of time. But what we've seen is that even ones where it did take that lot of time, we're beginning to scratch our heads. It's really reaped important dividends in terms of the things that really matter, which is scaling up of evidence-based services in otherwise underserved populations. resource mobilization, nothing new there. It's never easy, and in the current climate post-COVID, it's proving pretty adverse. But I think the main message is around demonstrating the value and importance of mental health service integration, but also integrating within the health system strengthening approaches, whether that's through primary health care or universal health coverage approach, making it a core part of that broader policy and agenda which many countries are seeking to move towards. The other perhaps main learning is through at the level of the program implementation. It's not at all predictable how things will go, and it's certainly not linear. Some countries, as I mentioned, have been slow to start but are now picking up. Others were quick to move ahead, and so you've got to be very agile and flexible in terms of what countries are able to do within their own within their own structures and institutional arrangements. The service, many of the countries had quite ambitious plans to reconfigure their services, and this can't be done just in a kind of isolated sense. It again requires a very systemic, integrated approach, which is why the sort of system strengthening aspects of this program have been very important. Looking at the workforce requirements, looking at how are things going to be governed at a district level, for example. How can we be introducing appropriate monitoring systems for detecting change over time and things like that. But on that final point, the monitoring, it has been made quite challenging by the relative weakness of information systems in the area of mental health. So we're hoping that this is something that we can strengthen and leave as a legacy of the program. So this is some initial reflections, but let's get into some of the real details at the country level. So I'll stop there and pass it back to, is it to Giovanni or straight on to Hasina? Go to the
Thank
next.
you very much. Thank you, Dan, for the very clear and complete presentation. Yes, before I pass on to Hasina, I just want to say thank you to all of you once again for being here. My name is Giovanni Sala. I work at WHO HQ within the Department of Mental Health and Substance Use. I support countries in the implementation of the special initiative. And I would just like to remind you to please use the Q&A function for any questions you may have. As we go through the presentations, we will try to answer as many of them as possible at the end, once we're done with the two upcoming presentations. So without further ado, let me introduce you to our colleague Hasina Momotaz, who is a National Professional Officer for Mental Health at WHO Bangladesh Country Office, who will talk to us about capacity building for the coordination and provision of mental health services in Bangladesh. Please, Hasina, the floor is yours.
Thank you for giving me this opportunity. Bangladesh has joined in the Special Initiative for Mental Health in 2019, and through this initiative, WHO is supporting government of Bangladesh to strengthen the mental health system of Bangladesh. Next slide, please. Bangladesh has a high population density of 171 million, and according to our national survey, 18% of adults and 12% of children are suffering from any mental health condition, and the treatment gap is also very high, which is 92 to 94%. Stigma and discrimination related to mental health is also very high. People do not feel comfortable to seek support for mental health. We have a major gap in human resources also. Only 300 psychiatrists and 6 psychologists are available for this 171 million population, and most of them are providing services in the urban settings. Bangladesh is also providing a major humanitarian response to more than 1 million forcibly displaced Myanmar nationals in Bangladesh. And Bangladesh has a very good tier-based health structure where specialized hospitals are in the tertiary care at the top of the pyramid. So there are only 2 specialized hospitals for mental health in Bangladesh, which include total 900 inpatient beds. And in the next level, you can see that there are the district hospitals where the medical college hospitals are also there in the secondary tier, but psychiatry units are not available in those hospitals. There are around 300 inpatient beds in 48 medical college hospitals. And there are also 64 district hospitals, but no mental health services are available in the district hospitals also. In the primary health care, there are sub-district hospitals, union sub-centers, and also the community clinics. Next slide, please. So if you see the current mental health system, most of the mental health services are available in the tertiary care. Almost 68% of the people received mental health care from this tertiary care, whereas only 32% are receiving care from the secondary and primary health care. So our target of this intervention we take is from the secondary health care, especially in the sub-district level, where the doctors and nurses are available. So we have conducted the MHCAP training for the doctors and nurses in the government setup of the Upujoy Health Complex, which is the sub-district level. So after this training, they were able to assess, manage, and follow up of mental health conditions, and also make referral to the tertiary healthcare centers. And with support from WHO initiative, government have established 19 mental health service centers in the sub-district level. To reduce the stigma, the name of the centers were also chosen very differently, such as the window of the mind or let's talk, so that the stigma can be reduced. And also the tele-mental health facilities were established in those centers, which are connected with the hub centers, which are based on the tertiary care hospital, where the psychiatrists, psychologists, and the mental health professionals are available. And in the community level, also we have conducted awareness program. Our ultimate goal is to reverse the pyramid so that the mental health services are strengthened in the community level. Next slide, please. To increase the local capacity for the coordination and provision of mental health services, lots of activities were undertaken. Government endorsed the National Mental Health Policy, Strategic Plan, and Mental Health Act in the national level. And mental health investment case also played an important role for the advocacy. Furthermore, a technical committee and a working group committee formed by the government at the national level to make important decisions and also to develop plan for the mental health programs. At the district level, WHO supported to build capacity of civil surgeons who are the district level authority of the district through orientation on mental health and exposure visit for the community-based mental health programs. In the sub-district level, there are some trainings provided to the service providers. One of these trainings is a 3 days long MHCAP training and also 5 days long TOT on MHCAP. And also some service provider receives a longer duration training that is for 3 weeks. And some very few of service provider also receives training like 1 month. In the community level, we observed the World Mental Health Day and also organized the art competition on mental health, conducted community engagement programs with civil society organizations and NGOs. Next slide, please. In the sub-district level, people come in the inpatient, outpatient, and the emergency department in the Monerbari or the Let's Talk or the Windows of Mind, the centers, where MHCAP trained service providers are available. If they identify anyone with the mental health conditions, then they refer those persons to the mental health center. And the person receives services from the doctors and nurses who have trained in the MHCAP. If the person needs any further support, they connected the person to the hub centers for psychiatric or psychological support, and that is in the district level or in the specialized hospital. At present, this special initiative is implementing mental health in 10 districts overall in the Bangladesh, and 4 district has the mental health service centers. From June, you can click on the next one, please, Celia. Yes, from the June 2023, we have started to collect the data on mental health, and we found that there are more than 7,000 persons have received mental health services from these centers. Next slide, please. Although Bangladesh is progressing in the mental health area, but also there are many challenges. We do not have enough resources for mental health care, and mental health is not significantly included in the medical curriculum. So there is always a need for capacity building. Another major challenge is psychotropic drugs, which are not available in most of the centers in the sub-district level. And also the patients are buying medicines from outside pharmacy. So the out-of-pocket money is using, and also the referral mechanism is not functioning very well. Patients are directly going to the tertiary care hospital and for treatment and follow-up. So the patient load is increasing in the tertiary care. Another challenge of mental health data is not available in the national database such as DHIS2. There is no data on mental health. And in the number of mental health research, monitoring, and evaluation is also very low in Bangladesh. To strengthen the local capacity, we need to continue the advocacy at the subnational level and also national level, and need to promote the deinstitutionalization. We also need to build capacity of service providers through training and supervision, and also community awareness is another important area to destigmatize mental health. We also need to focus on data collection and evidence generation. Finally, the multi-sector collaboration is needed to strengthen the mental health system. Thank you. So let me know if you have any queries or any questions. Over to Giovanni.
Thank you. Thank you very much, Hasina, for the very clear and fantastic presentation. We have already some questions that have come in. I think possibly some of them are directly for you, but let's wait until the end of our third presentation to get into them. Let me now introduce you to Liliana Urbina, who is a consultant at the Argentina PAHO country office, who will tell us about the lessons learned from Argentina in transitioning from facility-based to community-based mental health care. Please, Liliana, go ahead.
Thank you so much. Let's go to the next slide. Good morning, everyone. So I will focus on the deinstitutionalization process only, out of all the different activities we do in Argentina. So just to put you in a context, an overview very fast, Argentina is a country that counts already with a policy, a plan, and a strategy for implementation, different specific programs for suicide prevention, etc. It has a legal frame quite solid with national mental health legislation, which is aligned with the international standards, targets to deinstitutionalization up to closure of psychiatric hospitals. It has an administrative structure of directions of mental health at the national level and subnational level since Argentina is a federal country since the 80s, for example, and the political commitment, it's been going up and down across the years, yet after the pandemics, it was quite strong, quite high, quite focused on accelerating the implementation of the legislation. And for that reason, they empowered a lot a body that was set up by the legislation, which is the Interministerial Commission for Mental Health. And there all ministers sit under the coordination of the Minister of Health, and they take decisions, let's say, just to articulate actions, but these decisions are accompanied by budget from housing, from social welfare, from education, culture, labor, etc. Therefore, they managed to increase the budget destinated to mental health, taking it not only from the health budget, but also from the different other ministries which were committed to collaborate with implementation. As a matter of human resources professionals, mental health especially, those psychiatrists and psychologists, the country is really, has a lot of human resources, is much higher than the average in the region, yet these human resources are concentrated in the urban areas, in the private sector, and the institutions. There are some experiences, good experiences of working towards the institutionalization and setting up community-based, but still these are quite isolated and not well systematized. And Argentina got additional support from special initiatives starting from the end of 2022 when we joined the program. Yet we have all these positive things on the one side, but yet in the census, the only census that we conducted, that it was conducted in the 2019 on psychiatric population, we still have at that time 12,000 inpatients living in private or public psychiatric institutions. We assume that today this number is lower because there is a tendency to decrease the number of beds in the psychiatric hospitals, yet the institutions remains. There have been many efforts made at primary health care level, but it's not quite effective, and very limited, very poor development of the second level structures, both at the community-based level or integrated with the health system, let's say in the general hospitals or emergency wards, etc. So the secondary level is not developed. So we have on the one side the big institutions, tertiary level, and the primary health care level. In the middle, there is emptiness, or there is very, very poor development. So for this reason as well, psychiatric hospitals remain and retain most of the resources that were destinated to mental health. Can you go to the next one? For example, we conducted the cost analysis in Santa Fe provinces, and 95% of the budget was destinated to 3 mental institutions. In Argentina, we are working in different regions. As I told you, it's a federal country, so some provinces are more advanced, some less. The most advanced is Buenos Aires province. Why? Because it has a political committed continued all along these last years, and they have taken very strong decisions like non-admission policy, setting up of residencies, reinforcing the community-based and the secondary level of mental health services, and they have also provided support for the institutionalization of inpatients, providing financial support to go back home, labor, housing, etc. In a similar way, we worked in the province of Santa Fe, helping them, supporting the process that was already ongoing, and helping them to set up a community mental health center, a protected house, and working together from the community center together with the psychiatric hospital in order to set up the externation, I don't know how to say them, discharge teams, we call them, and in collaboration in between the groups. And we managed in this way to reinforce the process so that we could close down one ward last year of the main psychiatric asylum in Santa Fe. We have similar programs for La Rioja, Neuquén, Mendoza. I won't go into the details. We can go to the next slide, but still in every place the process is different. And here this is the science skills are quite limited, but this is the situation. If you see now the situation we have in Argentina, so big, huge, isolated, and totally closed in the center, the psychiatric hospital with the free entrance. And in this country, the teams have done an effort, as I told you, to discharge patients. There are very few community structures or services in the general hospitals, for example, but still these are isolated and not worked, and this doesn't work as a system. Can we go to the next one? When we speak about deinstitutionalization, we may think, as in the first square that you can see in this slide, that as much as we increase community services, we reduce institutional services till the point when we have no institutions, closed institutions, and we have all community-based. But actually, it's not quite linear, the fact. To my experience, it goes more like the second square, where you have by steps. Every step, let's imagine you have a psychiatric hospital with a ward with 20 patients. You have that ward. If you have 5 patients or 19 patients, you still need to keep the ward with all the personnel, the running costs, etc. If you manage to work well, both inside the hospital and outside in the community, and having a strong deinstitutionalization team, then you can manage to discharge patients one by one progressively with all the supports. Every bed, every patient you discharge, that bed needs to be closed down. And therefore, you will be able to close the ward only when you succeed, you manage to discharge all the 20 patients. And only then you will be able to take the resources allocated to that ward and shift them into the community. And this goes by steps, and so on and so forth. And in every flat part of the step, what you can see is that there is a tension in the health system, because at the same time you are sustaining the ward and the community mental health. So you need in these moments to put additional resources to support or use a lot of imagination. Both are necessary. We are going towards this. Actually, the vision we have is no psychiatric hospital at all. But in this moment, we would like to have a situation like this one that I show you here. Main important policy for the institutionalization is the non-admission policy, which is not easy. It's quite difficult. And you have to keep a balance in between what you downsize and you create outside, because we don't want to leave patients abandoned. nor in the hospital, neither outside the hospital. So therefore, we need to set up more community structures, more networked with the integral health services. We have to work with defined territories. And I admit that a non-admission policy is a very difficult thing to negotiate. But if you work and you put a lot of resources and strength, for example, one of these territories that I have defined there, and you put resources, you set up a center and you work together. This is what we have done, for example, in Santa Fe. You work together with the teams, you accompany to change the modalities of work, you do some things in order to change the inertia inside the hospital. Then you may negotiate that for that area, for that geographic area, which is covered by the mental health center, the protected home, the general hospital with the acute care ward, etc., and so on and so forth, for that region, then you won't have admissions in the psychiatric hospital. So this is a way to go progressively and slowly going down to this, going to this policy of non-admission policy, which is very, very difficult to convince ministers to do. And of course, networking all these services and all what I haven't put here, which is the community work and all the resources in the community. I just have put in the scheme the health services, but you have much more clubs, all what we know, the resources that the community can offer. Can we go to the next one? And this as a conclusion, I will be very fast. What I could see that was working well was setting up the institutionalization teams and making them mix of personnel working in the psychiatric hospital, involving not only doctors or psychologists, also nurses, mainly nurses, users, families, etc. Setting up an intersectoral body for implementation is quite useful in order to increase resources to facilitate the process. Making a cost analysis is something that can give you a lot of arguments to defend the institutionalization. Before starting the institutionalization, please fence the budget, because whenever you downsize something from psychiatry, let's say psychiatry, because it's not mental health, it's psychiatry, you have the risk that those funds go to another sector, sexist sector of the health, and you have to be careful not to lose resources in the way. To build up alliances, of course, to gradually shift resources from the institutions to the community base. This is the other difficult but very important issue to emphasize. Of course, having a secondary level is essential. If not, it's not possible that we think that only psychiatric hospitals or primary health care can deal with all the issues. Close the admissions, the non-admission policy for defined geographic areas, as I have already said. Reorganizing internally the institutions, because the institutions have an inertia that we need to break in order to change. Involve and empower everyone in the process, especially, I already mentioned this. And the most important, in my opinion, is long-term inpatient discharged, long-term bed closed, emptied ward, closed ward. This is in my opinion, the way to be sure that we really succeed to downsize psychiatric hospital. This is all. Thank you so much.
Great. Thank you. Thank you very much, Liliana, for the very detailed presentation, looking at very practical and pragmatic aspects of deinstitutionalization. We have received quite a few questions, so let me go quickly jump back to Dan. If you would like to answer the following, Dan, regarding indicators within that we are using within the special initiative. So which indicators do we use to assess and or monitor the quality and impact of the services that we set up through the program? You are on mute.
Yeah.
Yes.
Can you hear me okay now?
Yes.
Yeah. Great. I think that was a question from Denise. Hello, Denise. Good, you could join. Yes, indeed. I mean, I mentioned at the front, that we have some of these core cross-country indicators we're using to look at the performance of the initiative as a whole, looking at some of those input things like numbers of people trained, organization engaged, and then some more what I could describe as output measures like numbers of people coming into contact with services. But you're asking about, I think, more around the final part of that value chain, which is the actual outcomes of, for example, service users. So that's what we're going to try and address this year through as what we're calling a sentinel surveillance study, which will require some additional questions. But we're trying to do this in a real world naturalistic way, i.e. not do a research study as such, but more try to evaluate in real time what is the has been the effect of coming into contact with services and thereby address the questions around quality and impact. So some of the measures for quality would be appropriate use of psychological treatment where indicated, and indeed same for medications. For example, whether there is a follow-up visit indicated. But we're also going to be asking some very short questions about functioning. And we've chosen that because it's transdiagnostic. We're actually going to use some of the core questions from the WHO Disability Assessment Schedule, HUDAS-2, to get at the outcome, the functioning outcomes, as well as asking days out of role and things like that. So this is how we think we can realistically measure in real time the impacts, and hope that the value of that information is seen and therefore gets kind of plugged into routine assessments in routine care.
Great. Thank
Back
you
to
very
you,
much.
Giovanni.
Thank you, Dan. Let me jump over to Hasina then with a question specific to Bangladesh. So this is actually a three-part question because lots of questions are coming in for you. What are the mental health services that are provided in primary care in Bangladesh? And what is have you been working with lay community workers? And what about the work with traditional healers? Has anything been happening in that sense? Thank you, Hasina.
Thank you, Giovanni. So at present, we are focusing on the MHCAP training in the secondary level healthcare, that is sub-district health complex. So when the patients are coming in those centers, then the MHCAP trained doctors and nurses trying to treat them, and they provide the primary management. And if they need the further support, then they connect them to the hub center, which is from the specialized hospital. But from the lower level, such as community clinic, we have not started any intervention yet. But previously, there were some training that were conducted for the religious leaders and traditional healers. So the outcome happened that the referral become low after this training. So they are now treating in the sub-district level health complex after this training.
Great. Thank you very much, Hasina. Let me move over to Liliana very quickly with a question coming from Cameroon. With regards to how has the Trieste model informed the reform process in Argentina?
Influence, you mean the influence? Yes, it's been strong. Actually, Argentina has a strong connection with the Trieste experience since many years. And especially after the approval of the legislation, they have been cooperating a lot. Yet, even in Santa Fe, they had a collaboration, and we articulated the whole thing together. Yet I must say that a lot it's been learned, of course, of this Trieste experience, but none of these experiences can be imported. I mean, every place has its own path.
Of course, great. And while we are with you, Liliana, can you tell us about under challenges, when you mentioned the challenges in implementing in Argentina, it was mentioned that primary healthcare, mental health services were not very effective. What factors do you think are responsible for this?
Well, you see, actually, we have very extended network of primary healthcare services. Yet they were not working with mental health at all. We had the first launch of MHGAP in the years 18-19, then it was discontinued, then now we have taken this and once more. But what we understood from this experience is that MHGAP was taken as a plain training program only. So training of trainers, cascade trainers, trainings, and so on. But then we didn't know how effective this was once these people trained went back to their own services, where they are really under a lot of pressure with precary conditions of salaries and so on. And therefore, now we have again launched MHGAP with another way for implementation, with a close follow-up together with the ministry. Well, this was the way until the last year. We have now a change of administration, so let's see how it goes. But working together with the Ministry of Health, and then with all the provinces, decided to go ahead with MHGAP. We prepared assessments and then planning and then monitoring and evaluation, and not only with indicators of results, of process indicators, also including results indicators, because we want really to measure and make it understand that MHGAP is, yes, a training program, but it is also a way to articulate in the first and secondary level and facilitate the whole day institutionalization process. We are now focusing a lot on this and insisting a lot of this. We are now seeing that there are much more advances in implementation of MHGAP. Let's see if we are successful to make a real change. And I think this Sentinel study will help us a lot to measure this as well.
Thank you. Thank you very much, Liliana. A very interesting question has just come in. And this is both for Argentina and Bangladesh, but let's move to Hasina again. What have been the key factors driving political commitment in Bangladesh in the last few years around mental health and for the special initiative?
Thank you, Giovanni. So as you know that Bangladesh is prioritizing the mental health and also the neurodevelopmental disorders from the last several years. So that also have a commitment to the Directorate General of Health Services. Now the Directorate, they are also planning to develop a new operational plan for the government, and the government has also developed the mental health strategy, mental health action plan, mental health policy, and mental health act. So it is also included in our essential service packages. So these are all for the political commitment, and also the team who are working for the mental health, such as the National Institute of Mental Health and also the NGOs and the civil society organizations. So they are working better, and there are also some multi-sector collaboration between the different ministries. There's some collaboration with some different partners, organizations. So, and also WHO is supporting for the technical guidance. So I think that all of this has a impact on the political commitment. And also we have conducted an investment case which also used for the advocacy tool that more investment should be in the mental health. So this was a little bit. Thank you.
Thank you, Hasina. What about in Argentina, Liliana? What do you think has played a role in influencing or increasing political commitment for mental health in the past few years?
It's a difficult question, actually. Well, there is a critical mass of people here in Argentina, professionals, users, which is debating the matters of this change of paradigm for long years now. So there is a social pressure, let's say. And then I think there have been, how to put this, some governments, some administrations more sensitive to the issue and to the fact. And really, one peak was, for example, when the legislation was approved. There was a whole move. We also supported from WHO and PAHO, and this pushed a lot. It got a lot of consensus, also a lot of enemies, which are prepared there to try to change the legislation at every opportunity. And then I think the pandemics. The pandemics, when we came out from pandemics, the policymakers were really interested. They called and they insisted a lot for Argentina to be included into the special initiative, and they made this strategy for implementation and so on. Really, they invested a lot. So, and in that case, I believe it was the urgency to cover the needs after the pandemics. Of course, we do a lot of advocacy as well, and I hope that some is a result of our advocacy as well.
Absolutely, absolutely. Thank you so much, Liliana and Hasina. I think I would dare to say that our time is up, because with 2 minutes left, I'm not sure if we have time to properly answer any other questions. There are many that we could not answer, but we will do our best to answer them after this webinar. And I will let Joy say a few words about that. But before I pass back to Joy, another big thank you to all our speakers, and a big thank you to everyone who has listened in. It has been a pleasure and an honor to be with you today. So thank you, and over to Joy.
Thank you very much to the panelists, the attendees. Thank you for the amazing webinar. So for the question and answer, they will be presented. We will send an email to all those who registered, and they'll also be available on the MHIN website, and we will also send the link both to all the registrants and also available on the MHIN website with all the details, and there will also be an accompanying blog on the same. So thank you very much for attending, and we wish you all the best day, evening, night, wherever you are. See you. Thank you.
Thank you so much. Bye.
Bye, everybody. Thank you.
Bye-bye.
Thank you. Bye.